Okay, so uh, my name is Kurt Bertram. I'm a CPO and I work at O&P Insight. And I have the pleasure of having my colleague with me, Susie Ebersbach, who's in charge of our reimbursement uh, issues, and she's our reimbursement analyst for O&P Insight as well. And so one of the things that we've done with Ethnocare is partner with them because we know that this being a novel new device and coded with a 5999 code is going to provide some reimbursement downward pressure for all of you when you go through the RCM cycle. So some of the things that we do at O&P Insight, obviously our revenue solutions, we do a lot of training, hence we're here today. Value-added solutions with regarding accreditation, Medicare enrollments, all that kind of good stuff. We do a ton of compliance audits and work with different entities regarding that. We do clinical consulting again today. And then we also offer a continuing stream of industry insights and 2025 predictions as well as a 2024 wrap up. Um, Ethnocare came to us through a colleague that I've worked with for a number of years, and we realized that there were some partnership opportunities, not only with Ethnocare as a manufacturer, but with Ethnocare's customers and clients with regards to reviewing claims, coding and documentation reviews and training, and also with auditing as well, right up our alley with the services that we provide. Reimbursement support is key, and that's what we're going to talk about today. Reimbursement webinar is part of what we're doing here on the second half of this one today. Detailed reimbursement resort support with regards to the exact claims, and I'll get into that in a second, and then different levels of other support. As you know, the overlay is coded with a 5999 code. And everybody about this time should hang up and give up and, hey, we're not going to use this product because it's miscellaneous code. Well, time out. The good thing about this is that Ethnocare early on in the product development went to the PDAC and said, "Hey, we think it's like a few of these codes, specifically this one. What do you think, PDAC?" And PDAC being the deemed authority for CMS and CMS in charge of the HCPCS codes, makes that by default the deemed authority for all payers that use level 2 HCPCS codes. So what the PDAC says is correct coding for pretty much all payers, and that's what we recommend at O&P Insight. So they came back and said, you know what? It's novel, it's new, it is a prosthetic product, but it's coded with a miscellaneous prosthetic code. So, initially you think, darn, we didn't get what we wanted. However, the PDAC did say, guess what? It is a prosthetic device. That also establishes the pathway long term for Ethnocare to make decisions downstream as to what they want to do with this information from the PDAC, i.e., go for a code. The good news is that we all know that that's how you establish new codes is miscellaneous. So basically, the PDAC said it's not like anything else that exists within the HCPCS coding system. It is novel, it is unique, and it is a prosthetic component. So in our total opinion, that's a win-win. And you have the backing of the PDAC as correct coding. So if indeed a payer said, no, 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 this is what you meant to code it, and a lot of Medicaids like to do that. You could say, no, 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 PDAC said it's this, and so we need to use this miscellaneous code. All right, we know there's a lot of coverage challenges. And that is the variability in payers and payers policies. And I'm going to introduce Susie here in a minute, and she's going to talk about, the claim and what that looks like. It does create an administrative burden. I can't sugarcoat that in any way, shape, or form, that miscellaneous codes being manually priced, a lot of times being manually handed or going in a separate bucket, take longer to process by Medicare. We know that. And they take longer to process through other payers as well. And it does increase the denial risk on a prior auth or a post-payment audit during adjudication. Well, not a post-payment, but during the prior auth or just being a miscellaneous code, it can create a denial process in the adjudication of that claim. So what are we going to do about it? The first thing is robust medical necessity documentation. Mark laid out a great plan that it is medically necessary for people to have adjustable volume management, articulated that extremely well. So that's what your notes are going to have to say, and we'll dig into that in a second. Uh, and the administrative process, which Susie's going to talk about, has to be meticulous. You can't, because there's more pressure on a miscellaneous manually priced code, there has to be a much more meticulous process with your administrative staff going down that road. So we're going to talk about documentation needs. We're going to talk about how the products and features feed into your medical necessity. And then Susie's going to talk about administrative processes. So physician documentation is the first piece of documentation. Remember that we as clinicians don't create medical necessity. That comes from the physician. So that's since 2011, we've had to have physician documentation, and the physician has to have created medical necessity within their documentation. So they need to address this issue of volume management in some way, shape, or form. And it is best practice to be able to grab that documentation, read it, hopefully before you see the patient, but definitely before you submit the claim. And the standard documentation policy article basically says this: supplier records alone cannot establish medical necessity. It's imperative that you get all your physician documentation buttoned up and make sure that it is going to not only establish that medical necessity on that initial order and everything, but mention it in their notes from their own notes, not something supplier generated, and not corroborate anything that you want to say in your notes. Not corroborate everything you want to say in your notes, not be contrarian to things that you say in your notes. Okay, so what does the physician need to say, and what do we want them to say? So medical need for volume management beyond SOX. Otherwise, we're just going to give them SOX. So Mark laid out a lot of points that SOX alone can cause issues. And there may be a specific, and there needs to be a specific need for the patient that SOX just really aren't getting it done. Document the expected medical benefit of the patient to receive implementation of a separate volume management system. So we're all using, as Mark indicated, the Revo fits and the panels for volume management. Recently had the inception of 5783, which is the mechanical volume management socket code. So it's gaining a lot of traction that, hey, SOX just aren't the end all to be all. And then vacuum, and we can go back to vacuum about how that is actually for suspension and volume management and all those types of good things. So it's not uncommon for us to use other means besides SOX these days, and it's been well established for a long period of time. And prescribes the addition of volume management systems. So if the physician uses these words in their documentation, that is what we're looking for. We're not really looking for the physician to solve the problem of the exact device you're going to use for this. It's just that, hey, yeah, I know they have a volume management system. I use Alex DeHenton as my CPO champion. So I'm going to send them to Alex, and Alex is going to tell me what exactly are, is needed for the patient. And in this case, hopefully it's the overlay that's needed for the patient. So it's the prosthetist that talks about the specifics of the device and everything. So the first thing you need is define the patient's medical need. And you can even extrapolate that out to what is the unmet need. Explain how the overlay is going to meet that need. And in this case, talking about the specific product is absolutely appropriate in your documentation, because there are things about the overlay that are specific to why you want to use that specific device and component. Explain why alternate solutions are ruled out. So especially socks at this point. So socks aren't going to work, and then we'll get into some rationale here in a second. Or a RevoFit might not work in this particular case, and then you can explain why. And then, if needed, we need to have some explanation about why the product is correctly coded at 5999, and there is no other code that matches that. And Susie will get into that a little bit more. But here's the the prosthetist documentation. So how do you document volume fluctuation? Well, you can do scans, repetitive scans over time. You can create an Excel spreadsheet and show how that happens. You can talk to the patient and depose them with regards to, what do you put on in the morning? What do you put on at the end of the day? Non-uniform volume, dexterity issues. This is a really interesting one. I actually had a claim that I was working on that was denied, and the patient was a lineman. And if any of you know, these are the folks that go out in the storms and put up power lines because they fall down from hurricanes, tornadoes, and all these bad things that happen. And they're dressed in very heavy gear, typically in the northern climates, it's cold, so it's winter gear, a lot of Carhartt, okay? And they cannot remove their prosthesis and their boots and everything they need to in their pants to be able to put on more socks. So this is an elegant solution to be able to work through their pants to be able to get the proper volume that they need to be able to hold their prosthesis on, which is extremely important for somebody in that type of work. Limb sensitivity or bell clapping or weight fluctuation. And these are all specific to your patient. So how do these specific situations, and again, this is just a guide for you to look at and say, oh, maybe that's what my patient's going through, and then describe what those situations are. Remember, insurance companies don't want to pay for devices themselves. They want to pay for solutions for their patients uh, to get to get the services that they need to be able to do their job, to be able to function in their ADLs, to be able to return to work, to be able to return to ambulation. Post-surgical volume, any kind of changes, irritation, and those active patients and those examples of the K4 patients that Mark showed are, real and do exist. So again, good physician documentation that addressed volume management issues or specific issues that you've talked to the physician about with this particular patient where the overlay will help. And once you get the physician to create that initial order and medical necessity, then you corroborate it and then you add in the patient-specific notes for that patient's unmet need as to why socks won't work. First, great place to start. And then how the overlay is going to manage and assist them with their activities of daily life, vocational needs, and or even recreational needs. So we have to make sure that that is really buttoned up on the documentation side so that we can move into the clinical side or the administrative side. So Susie, I'll let you take this from here.
Unmute. All right. So I'm going to go through this really quickly and just know that you can have your admin billing staff call O&P Insight for help with this at any time. So we're just going to breeze through. First, the benefit verification has to be careful. They've got to get information on how to bill the not otherwise classified code and make sure it is on the fee schedule. A lot of the Medicaids might have special procedures where you have to do certain things to get a not otherwise classified code covered. And so you've got to know that up front, but it's not just the Medicaids. All payers have different procedures for how they handle the not otherwise classified codes. So you need to know, does it require prior auth? There's nothing you can do about it. If you didn't get prior auth and it was required, that can't be overcome. You got to know how the allowable will be determined once it's covered. If their methodology involves the manufacturer's invoice, you need to know what you're going to recover based on the invoice. And if it's a percent of bill charges. You need to price accordingly. Also, it may be a contractual discount. So you want to know that up front before you submit your claim, so you've priced it so you won't have surprises. Then the procedures, if anyone tells you that they didn't need prior auth and it's a not otherwise classified code, you should be very specific, very suspicious of that. Aetna does do that for other reasons, trying to keep you out of the appeal process is what I think it is. But most often you will have to get a prior auth when you have a not otherwise classified code. So scrubbing the claim before you submit is really important. You want a compliant standard written order, that all of the proper elements are there, that you have justifications that are complete and specific to your patient. This gives you a place to point to that not only gives the justification, which you have to copy into your medical note for Medicare, but also has the physician's signature on that document. So that is signed by them that it's under their prescription. The physician documentation has to be creating the medical necessity. The patient has the medical need for a volume management system beyond simple prosthetic socks, and that they prescribe it. If you've got the SWO, you've got the prescription, but sometimes they just say it in a note. And then also that has to be properly signed and dated. And then the prosthesis documentation, you've got to explain the deficit, why the patient needs this additional volume management system. You got to explain why socks aren't going to be adequate, and explain that the 5999 is correctly coded, that the product has been PDAC verified as that is correct. And that may save you some time. You still may run into that their processes will require that any not otherwise classified code has to send in records for it to be adjudicated. And if you've got all your steps, preliminary steps done correctly, that's pretty simple to comply with. Okay. And then the prior auth, you have to collect it, and then you have to make sure it's properly submitted. If you have it, you can retroactively correct it if you didn't properly submit it, but you have to know their procedures for getting that submitted. And then the manufacturer's invoice, you should go ahead and preliminarily get that into your chart so that if you need it for reimbursement purposes, it's already there and available for the admin staff to complete documentation requests. And you have to check that your billed amount is going to give you the expected allowable. You have to know the methodology they're going to use to process a not otherwise classified code in order to be sure of that. So that could be multiple things. Proof of delivery has to be including the serial number for this part, just the model. It might just say Ethnocare overlay. That's fine. It doesn't have to have an individual serial number. And then it needs to be signed and dated as required by Medicare. Even if you do all these things, you still may get denials for not otherwise classified codes, because sometimes that's just part of the payer procedure that they need to review records. And that happens even if prior auth was given. But if you need to submit the prior auth too, sometimes that's what they're looking for. And sometimes they're looking for information to determine the reimbursement. So you might have to submit the invoice, or you might have to tell them, what the contract says it should be paid as. And then sometimes they'll say the code is incorrect or unbundled, and you just go to the PDAC website, print the product classification list that says it is PDAC verified as 5999, and that's the correct code, and that should take care of that. Also you can go to the next slide. On Ethnocare's website, they've got the PDAC letter. Their LMN has a summary of the clinical presentations that Kurt went over that will help you in your documentation to support the medical necessity. They've got two things on there, the reimbursement guides and clinical guides. You can use the CMS policy article and LCD and standard documentation as general guides for how to handle this documentation. And then on the PDAC website, I already explained, you can look up the classification list and see that Ethnocare overlay is on there, verified as a 5999. And then you can always call us or email us, and we will get back and I will help you to my best of my ability.
So I wanted to make sure that everybody on the call knows that we work closely with Ethnocare and you as potential customers for the overlay. If you're having specific claim difficulties, we can work with you to assist you in determining and helping you, with an appeal. One thing that we need to be very clear about in this case is that uh, if we do not, and you have not been a client of O&P Insight, we cannot accept any PHI or specific claim activity from you until we sign a business associate agreement and get on board with being compliant with HIPAA and privacy practices, which is easy to do. If you need general, like this presentation was a general guide reimbursement, we're more than happy to engage with you on Ethnocare's behalf to be able to help you with a claim. But anything until we get the business associate and privacy practices squared away with you, we're not allowed to accept any PHI or specific claim reimbursement data at that time.
Hey,
So,
I have a
Mark,
question.
oh,
Oh,
Tom,
I'm sorry. Yes. First of all, I apologize, but I have to get off this call for a 1 o'clock patient telehealth. But I have two questions. One for Susie and or whomever, but I think it's in Susie's domain. Is if we want to provide this with a new device, and this is the only NOS code, the only 99 code, are all of the charges going to be denied or held until this particular code is authorized, or should we bill it separately? What's your thoughts on that?
Not usually. Medicare today will separate that onto a separate ICN and process everything else. Some payers may hold up all of the codes that are in that set of 6 or whatever their increment is for how many codes they allow on a certain EOB line, or they may pay all the other codes and just have a denial for that one line item.
Mhm.
Typically,
Okay, that was one. The,
yeah,
the other question I have is this a distributed? I am sorry, I'm getting calls to get on this thing here, but can you all still hear me?
Yeah, yeah, absolutely.
Okay. Is this a distributed item
Yep,
through Cascade or Orthoped or
absolutely.
all
I
of them?
we missed that slide, but definitely we are available to Cascade, to SPS, to any distributor in North America. We're available everywhere.
Okay, so the last thing I want to say is thank you. This is very creative, hopefully useful device that we can all get paid for, and you're hanging out with the right crowd, you guys, with
Thank you.
O&P Insights. So good luck, thank you, but I got to ski daddle, and I will take the test later.
Perfect. Thank you,
All right.
Thomas.
Yes, thank you too very much.
Is there any other
Where am I
questions from the crowd?
here? There we go.
any other questions? You got us on the phone. Sorry for calling you out, Alex. I miss you, and I just saw that you joined. So you are one of my favorite prosthetists ever. So
This is recorded, Kurt, so it's gonna be everywhere now.
I know I gotta make sure that yeah.
All right, perfect. Well, if there's no more question, remember that there is the link for the CEUs in the chat, and I'll pass it to Jean-Gabriel to just sum up everything, and I think we're good to go.
Absolutely. Thank you, Mark. I'll also make sure to send you a recap email with every information you may need about that presentation. If you have any other question that pops up in your mind related to that webinar also, you can always send me an email related to that. I've sent some information in the chat also regarding our social media and our main point of contact email. So I think that would be pretty much all for us today. Thank you very much to everyone who participated. Thank you, Susie. Thank you, Kurt. Thank you, Mark. I hope it has been super helpful for you guys, and I'll wish you a great end of the day.
Thank you, everyone.
Thanks, everyone.